Alrighty, for those of you who don't know me, my name is Sherri Lorette Blakeman, and I've been a hospice nurse for 15, 16 years now, the last 10 with Beata Hospice. So I know hospice a little bit, which is awesome. So, hospice, what it is and what it is not. Hospice is about taking care of people when they're in their last 6 months of life. You're behind the bar.
I'm sorry.
It's going to bother you. Anyway, so people in the last 6 months of life. Now that's not, it's like a magic number, okay? And you're not obligated to die in that 6 months, okay? Because some people are like, well, what if we get to the end of 6 months and I haven't died? Do I need to come off of hospice? No. I've had people on hospice for several years. I mean, I think we have someone on that's been on for 4 years now. That's a long time. But anyway, but what happens is when you're on hospice, a doctor needs to look at your case and look and see what you're doing and how you're declining. And at the end of each cert period, which is a period of time, they have to look at you and go, you know what? If this person goes on the expected trajectory, I would anticipate that they would die in the next 6 months. Again, you're not obligated to. And I find that sometimes on hospice, people actually get such good care that's why they live longer than their 6 months time frame.
That's nice to hear.
I mean, it's true. There are people that it is by the grace of their caregivers that they're still with us, and no other reason at all. What hospice is not. One of the things that hospice is not is it is not time, like block time. When we go in as a team, each of our team members goes in. We're there about an hour, hour and a half, depends. But we don't go in and do like 4 hours, 6 hours, or 24/7 care for people. So some people think, oh, they're coming on hospice. Now somebody's going to come in 24/7 and take care of my loved one. That's not what we do. So just a snapshot. Oh, what did I do? I have to push that button. Thank you. Oh, this is me, Sherri Lorette. Just in case you didn't know. Previous experience. Anybody here had previous experience with hospice? I know the answer to some of these. Yes? Yes? Anybody else? No. Okay. Good experience, bad experience.
Wonderful. Wonderful with you, different with my sisters.
Oh, there you go. Okay. Good, bad.
Good.
Okay. In general, hospice, the way I like to describe hospice care is we're coming in to not only take care of the patient, but to take care of the family or caregivers, teach them the things they need to know to take good care of their loved one, make sure that they have the tools, the medications, the support that they need. I kind of envision us as a net underneath everybody, holding you all up to get you across the finish line. And so that's kind of the vision that you should be thinking about. Boom. Why hospice? Why now? That's the question I ask every time we admit somebody. Why are they coming onto hospice? And why are they coming onto hospice now? So somebody may have, say, like a cancer diagnosis, and they've been fighting this cancer for 6 years, 8 years, whatever. So why is it just now we're talking about them coming onto hospice? And has the circumstance changed? Are there no more treatment options? Their decline is such that they look like they will die in the next 6 months. And again, that's a doctor. Actually, there's two doctors that have to say that. One is our medical director, and one is the patient's primary care doctor or their oncology doctor or whoever it is. So there's basically two doctors have to say that. But what's changed, So for, say, a dementia patient, well, they've fallen 3 times, and the last time they fell, they broke their wrist. And now she's really only getting around in a wheelchair. She's not eating very much. She's lost 12 pounds in the last 3 months. There's some real definitive things that are showing a pretty steep decline. Now this person looks like they're a person who should be coming onto hospice and getting hospice care and the supports that go with that. So there's always like, what has changed? What looks different? So that's the why hospice, why now? people who can receive hospice care, I think oftentimes we always think of our cancer patients should be getting hospice, and for the most part, that is what we do see a huge percentage of those as well. But anybody who's got end-stage cardiac disease, congestive heart failure, whatever, their heart just is not functioning on a very great level, and they're really declining. They're requiring a lot more help. Getting up and walking to the bathroom is quite an event. Any of those kinds of things. Can no longer sleep in bed. They're sleeping in a recliner. So that type of end-stage cardiac disease we see. Again, respiratory disease, I think of the people who have COPD, emphysema, chronic bronchitis, that sort of thing. Again, they've gotten to the stage where getting out of bed and just getting to their recliners, a big event. They're on steroids. They're using oxygen either continuously or a lot during the day or whatever. Maybe they've had multiple respiratory infections. I always say my COPD patients, they're one infection away from dying because all they need is one really good event. Pneumonia, bad cold, COVID, and they're done. Alzheimer's or dementia, we talked about that, but it's really, again, you can have Alzheimer's and dementia for years. But it's when you get to a certain point, and generally the things that we're looking for is lots of falls, they're losing weight. Some people, even when they're still eating well, they don't absorb those nutrients, and so they might eat like the truck driver, but honey, the weight just keeps dropping off month after month. So those are the kinds of things that we're looking at. Verbally, they're not as clear. They're not able to process mentally as well. There might be some behaviors. There might be other things that are going on. They're not able to walk with their walker anymore. They're using the wheelchair more. Those kinds of things. So as we start seeing those declines in our dementia and Alzheimer's patients, they tend to qualify for hospice care. ALS, otherwise known as Lou Gehrig's disease. Again, you get to a certain point and they can't maintain their weight. They're having more and more difficulty with breathing. Do they want to be using a breathing machine if they don't? They're getting to the point where their muscles are getting to the point where they're so weak that over a certain trajectory of time, we expect that that'll be the thing that will take their lives. End-stage kidney disease or liver disease, again, just as those organs start failing, and especially the people who are end-stage kidney disease, if they're not wanting to go on to dialysis and their disease process is such, or sometimes it's people who've been on dialysis and they go, you know what, I am so done with dialysis. We're not doing this anymore. Then, depending on how much their body really depends on that dialysis, which for the most part is quite significant if they're on dialysis, that time frame could be a week or it could be even a few months. But in general, there's you see a big decline when people don't want their dialysis anymore. I've probably forgotten something else, but those are kind of the big ones. Who pays for hospice care? It's always a big question. A lot of people are like, well, I can't come onto hospice because I don't know if we can afford it. Well, you can afford it because Medicare has its own specific Medicare hospice benefit. And it pays for everything. It pays for all the things, and I'll go into what it covers in a minute. But Medicaid also pays for hospice care. So if you're not 65, you don't qualify for Medicare. You're not on disability, so you don't qualify for Medicare. And you're on the Medicaid, and most private insurances pay for it as well. And actually, I find that private insurances tend to maybe cover a few more things than like a Medicare or a Medicaid. But it's all sort of in the mix. But anyways, it gets paid for, and it's a non-issue. What's covered? Okay, so what's covered under hospice is medical equipment. So if you needed a hospital bed, a wheelchair, a walker, oxygen equipment, nebulizer for your breathing treatments, a shower chair. What am I missing? Those are the big ones. All those things are covered under hospice. So the medical equipment to keep you comfortable. Medications for comfort. So we wouldn't necessarily pay for like some of the really expensive medications that some people come on to us with, but we pay for medications that help with making your breathing feel comfortable, definitely to deal with pain. I think a lot of times people think about pain, but but also keeping people comfortable from a respiratory standpoint, itching, not being able to sleep well, anxiety, agitation, can't settle down, that kind of thing. So all those kinds of, being able to move your bowels regularly, all of those get accounted for. And then I always say treatments for comfort, and I think of things like, so sometimes people are on a pain pump, so pumps with medications would get paid for. I've had people that they accumulate a lot of fluid in their belly or in their chest, and so we'll put in what we call a Pleurax tube. Well, we don't do it; it gets done at the hospital, but we would pay for that so that we can drain that and keep that so it's comfortable. It's not like, oh, I'm so full, there's so much pressure, it's so uncomfortable. It's not pain per se, but very uncomfortable to have a belly that big. Hard to lay down because you've got all that fluid pushing up on your diaphragm, that sort of thing. So those kinds of things get paid for. Visits from all the team members, and I'm going to go through that in a minute. Visits from your primary care doc. So if you still want to go back to the office and see your primary care doc, that's covered. I'm finding more and more that the PCPs will actually go out and visit patients in their homes, which I think is just delightful, because at a certain point it gets to be too much work to get someone into a wheelchair, get them out the door, get them to the car, moving just from the wheelchair to the car, swinging the legs in, getting them comfy, put the wheelchair in the back, and then you get back, then you get to the doctor's office or Dartmouth or whatever, and then you got to do the reverse process. That's a lot of work for some people. That's exhausting. Mm-hmm. So if somebody can just come to the house and see them, that is sweet. But that said, you do not need to be homebound to be on hospice. To be on home care, you do. But you don't have to be on hospice. So you can still get in the car and go get ice cream, go to lunch, go fishing, go for an airplane ride, ride in the truck around the sugar bush. I'm trying to think of some of the specific examples that I can think of. So you don't have to be homebound. And I love it when people aren't. It does not cover block time for caregivers. We talked about that earlier. So we come in for, again, about an hour, hour and a half, depends on what's going on. So team members, and of course everybody, excuse me, I have a frog. I have a water over here somewhere. Sorry. I'll walk right into the camera.
Am I in front of the camera?
You're not? I mean, you're great. It's right there over your shoulder. Don't stand up.
Bad hair day.
So nurses, of course, the nurses come in our role. I know my role. You go in, you get a set of vital signs, you listen to heart, lungs, belly, get kinds of data on like when was the last time you moved your bowels, how are you sleeping, how's your pain really being managed, how much extra medication are you taking versus scheduled medication, any other issues going on that I need to know about, that sort of thing. And then we're the ones that also will, call the docs for new orders or get new equipment, because at this point, you gotten to the point where really you need a wheelchair now, let's get that. We want a hospital bed now, let's get that sort of thing. So we coordinate all that. So the nurse is the case manager, and she's the one that makes sure everybody else on the team is connected. Social workers we have, and I want to talk about social workers and spiritual care kind of more specifically with their stuff. Where did I put my paper? It's someplace really smart, but it's not. Oh, you're the best one. I knew it was here somewhere. My cheat sheet. So the social worker, spiritual care. We have a medical director. So our medical director is a doc, and he specializes in hospice care. And he's the one that I should say both, because we have several associate medical directors, all of which are women. We have one man. But anyway, if you're having trouble managing symptoms, so this is what's going on. This is what we've tried. What do you think about this? And he or she may make recommendations about where we would go next, or what recommendations we would take back to the primary care doc. One of the things about coming onto hospice is you don't lose your primary care doc. We want to keep them in the loop. They're the ones we really get our orders from, so they know what's going on. And even when I don't need orders, if I see people are sort of declining, I'm still calling that doctor and letting them know kind of where they are And they're like, so you don't need orders? No, no, just want you to know this is what's going on. Home health aides, so they're all licensed nursing assistants, and they come into the home and they will do things like bathing, helping change clothes, make beds. I make these plans out every week. What else do they do? You know, they might prepare a snack or a meal, make sure there's a fresh glass of water, you know, the new water bottle out of the fridge or whatever the deal is. And so they might do up the dishes in the sink. Now, if we've got this little old lady who's home alone and determined to stay home, you know, they might do something more like, you know, doing up the dishes in the sink, preparing something for lunch, giving them their breakfast, and then the lunch is sitting there ready to be warmed up at lunchtime or whatever. So they're wonderful. They're awesome. We have a hospice pharmacy that we work with in Clara, but there's other hospice pharmacies out there. And again, if I've got someone who I'm concerned about symptoms and I want to change something or tweak something, I may call them and say, this is what's going on, what would you recommend? And they would then recommend, you know, certain medications, start this way, do whatever. So then I can go back to the primary care doc and say, you know, I've spoken to the pharmacist, our hospice pharmacist, and this is their recommendations. What do you think? And they might say, I don't want any of that. I want to do this thing, and that's okay too. And we do whatever they want to do. But they're a great resource, which is awesome. We also have volunteers, and our volunteers do a variety of things. So volunteers might just come and sit with somebody, hold a hand, might read to somebody, might just hang out while the wife goes and does her grocery shopping or something for a couple of hours. You know, just give people a break so they can get out of the house. We have volunteers that will come and I've had them come in and put rails in, put in rails in a bathroom, safety rails. So more of kind of like a, you know, general, whatever I'm trying to think, carpentry sorts of things. Trying to think what some other volunteers do. We've had somebody used to bring pizza every week to this little lady. That's her favorite thing, to have pizza with her medical student, which was sweet.
Water the plants.
Water the plants, you know. So just sometimes it's just little tasky things. Usually it has, you know, like I used to have a volunteer that would go out and play cribbage once a week with a patient. You know, it's just whatever they want from the volunteer. So you never know. Sometimes they want a volunteer to take them out of the house. They want to go down and get ice cream or go do their own grocery shopping. Okay. So you have a volunteer that can do some of those things. So it just depends on people's level of what they're willing to do. Volunteers are awesome. Okay. Did I want to? No. Bummer. Bummer drag. Now I got to do something different. Hang on. I'm figuring it out.
We'll be right back.
Oh, there we go. Perfect. My little cheat sheet. Okay. This is what I want to do. Okay. So we talked about social work and spiritual care. So one of the things that when I go out and I do an admission, and if you say the word social worker, sometimes that gets a little visceral response. I don't know what that's about. People have a history with social work, and they don't want a social worker in their house. They have no idea what the social worker might do for hospice, but so sometimes I don't use that word. I say my other teammate, Nancy, would be really helpful to help you with some of these things, and I don't use the social work word because that really causes consternation. So some of the things that social workers do is they will connect people with community resources. So that might be they need private caregivers, and they need to know who's out there and who's available. And then we just, you know, here's some names, here's some phone numbers, you call them. And tell them what it is you need and see what they can do. They may need help. They may have long-term care insurance. And then I have the first idea how to start the paperwork to get long-term care to start paying for in-home private caregivers, whatever. So they can help them, you know, reach out, get the paperwork, help them fill it out, get it sent in, get them on board so these people can access the resources they've been paying for anyway. Or it might be, and I wish I could think of what the name of the Choices for Care, that's what it is, Choices for Care in Vermont. It's a program, you gotta apply, but then Choices for Care will pay either a family member or private caregivers to provide care in the home. And that's really helpful if you really need some more hands-on care. They've also helped with, you know, if somebody has not started funeral home planning, and I see it all. You go and you say, well, have you even considered a funeral yet? And sometimes you get that deer in the headlight look. Like, you're not going to talk to me about a funeral. I'm like, I'm having all I can do to deal with the fact that I'm coming onto hospice today. So you just backpedal really quickly and you say, well, you know, sometimes people have thought about this and sometimes people haven't yet. And it's with no rush, just asking the question out loud. But then sometimes you'll say, oh, yeah, no, that's all paid for. I picked out the hymns. We're good. No, yeah, that's all set. I'm like, oh, good for you, you know, awesome. Love those people.
Then you ask, where did you do with the paperwork?
They usually have it though. Those people are organized. There are people who have not done anything with an advance directive. You know, up until then, it's been full court press. We're doing everything. We haven't really pondered advance directives. So social workers can sit down, or maybe they have a set, but they're 10 years old. And now we're here today in a very different place than when I filled out that paperwork a while ago. We need to update this. So social workers will sit down and walk through it step by step, help them figure out and fill it out, get it signed, send it to their doctor, get it signed, do whatever. Okay, so they help with doing all that. And then some of those are kind of like concrete things. Other things that they do is just sit and visit and listen. It's amazing how much of this job is listening. Really allowing people to do life review. And what does that mean? Basically, it's like, so what was your life about? Tell me what your life was. Well, you know, I used to be a farmer, and I had 6 kids, and we did the thing, and we used to go to Canada once a year to go visit my aunt, and whatever, you know. Like, so they just tell their life. But in the process of talking about their life, and talking about their kids and what their kids are doing, or their grandkids or great-grandkids or whatever, you start to see what the values are that that person has. And what it helps them to do by having that conversation is it helps them to understand, what was my life about? Why did it matter that I was even on this earth to begin with? So life review, is a lot of that is about just helping people to sort of get a perspective of why it mattered that they were here. So life review is really important. They also work on closure of relationships, and I'd like to talk about that in a minute, but I will talk about that some. So as you can imagine, not every patient/family that comes to us necessarily comes from a healthy family environment. A lot of dysfunction sometimes. I've got the estranged son or daughter. I've got the whatever, you know, haven't talked to them for 20 years. And this is an opportunity to say, do you know how to get a hold of them? Do you want to get a hold of them? Is there anything that you want to say to them before you die? And, you know, up until then, when you weren't going to die anyway, you could hold off on that. But now that you know you're dying, sometimes it becomes important to reach out and ask, you know, really, you're not going to fix it all. But sometimes just that one reaching out makes a difference. They also help with legacy things. Sometimes you've got people, young people that are dying and they have little kids, you know. And it's like, do you want to write some letters to your kids? Do you want to make some videos for your kids? So, you know, some people will write a letter for their graduation or for the day they get married. Don't make me cry. You know, those kinds of letters. And it's very important to then those get stuffed away for later. But those are important letters for kids when they grow up or as they're growing up. So I've seen people do videos, that kind of thing. Closure of relationships. Did I get to that? Is that on my next screen? Please tell me. Oh, there we go. Closure of relationships. I'm going to talk about this now. This is both spiritual care as well as social work. And you will find these things here in various places. But the 4 kind of tasks that people need to do is they need to be able to tell family members or friends or whoever was important in their life that I love you. So being able to say that, sometimes it's in a letter, sometimes it's being able to say that, forgive me, I've done this wrong to you, and, you know, sometimes I was kind of as a father or a mother, and I didn't handle this well, and I'm sorry, would you forgive me? Or you have the family member that's been awful to you, in your assessment, they've been awful to you, and you need to forgive them. Now, sometimes you don't actually have that conversation with said person because you can't get to them, they're not willing to come to you, whatever the deal is. But he still allows you an opportunity to have that conversation, maybe process what that looked like, and make a decision in your heart to forgive that person, even if you can't do it formally in a conversation. So, and that really, it makes a big difference in terms of, I find if people work their way through these tasks, they die better, they die well, they die with less conflict and less stress. And if you take care of these closure of relationships with your loved ones, they actually grieve better because these things aren't hanging there. You actually had that discussion. And saying goodbye. You know, it's hard to say goodbye because you then have to admit you're dying. It's also hard for family members to say goodbye. And I often call that giving permission. And it's really hard to go in and say, you know, Dad, it's okay. When it's time, it's okay for you to go. That's not easy to say either. So to have family members be able to give permission for the person to go can be hard. Spiritual care. Again, spiritual care. That's not something that everybody gets. If you're a Christian, it totally makes sense, you know. If you're Catholic in particular, there are specific rituals and things that you want to do. You know, you may want the sacrament of the sick. You may want to still be getting communion every week, even though you can't go to church, you know, whatever. So that's things that our spiritual counselors can do. They can also help with funeral planning. And it's actually not that uncommon sometimes for our spiritual counselors to actually do the funeral for a patient because they don't have any formal relationships with any churches or pastors or whatever. And so sometimes they get asked to do the funerals, and they do really nice jobs.
I have a question.
Yes, ma'am.
Do these people actually do the last rites and things, or do they bring the person's
Excellent
priest
question.
or minister or somebody in, or
Right. Yeah.
do they actually do them themselves?
So it will depend on the person. For the most part, I don't think we have any priests. We might have someone up north that's like in process of becoming a priest. I think at the Burlington office we do, who may be able to do that. But in general, what we would do is we would reach out to the local Catholic church and find a priest to do that. And I've certainly gone in and found somebody actively dying and said, and they go, and he's Catholic, and I'm like, has he had last rites? No. Or sacrament of the sick. There's multiple phrases for it. And they'll be like, yeah, I don't think so. Or like, would that be important? Yep. Find me a priest right now. And so we get on the horn and we find us a priest right now because we want that done. Because that would be an important thing. You know, my mother was you had to have the sacrament of the sick. Yeah. Good Catholic. Okay. Sometimes people want to write their own obituary. Haven't done that myself, but sometimes they help write their own obituary, which is kind of interesting because, again, that's part of that life review. What's in your obituary? Son or daughter of Mr. and so-and-so, and went to this school and, you know, was a farmer and worked for Goodyear Tire and did whatever and had 6 kids and, you know, and this is what, I mean, in essence, life review is writing your obituary. So sometimes they help them write their own obituary, which is kind of cool. Also just connecting to spiritual practices, and sometimes that's, and I particularly think of our dementia patients who are not able to really have a conversation on a spiritual level. Do you know what I mean? They're not having that kind of a conversation. But if you play some specific hymns that the family says to you, she loved this hymn. If you play those hymns, that so touches them. And you can see that it does, and it makes a big difference. So those are some of the things. Some people want you to come and say prayers with them. They want you to come and read the Bible. They want you to come and not even mention that Bible, thank you very much. But we can talk about other things, because I was with God when I was in the woods. Do you know what I mean? So it's a different conversation than someone who was a church attender. So I'm talking about this angle, but there's always this other angle. And sometimes people are not about that whole church thing. Don't even come near me with that. And I always say, they're not going to read the Bible. There won't be a quiz later. Okay, just so you know, that's not what this is about. But for some people, it's really just talking about what was important to me. What were those things that really I found fulfilling, and being able to talk about those things. Again, I think some of that fits in with the whole life review piece. But it's really like on a spiritual level, what brought meaning to my life, and what's going to bring meaning as I approach death. So some of those things. I've had them go in, they've read poetry, they've read books, and not necessarily spiritual ones, just I like people reading books to me. I always enjoyed my books. I can't read them anymore, can't focus, but if you want to sit and read me a book, I love it. Let's see. They can also just talk about, again, this having to do with finding closure in relationships and being able to talk about, this is the kind of dad I was, or this is the kind of friend I was or wasn't, or whatever, and being able to kind of talk about, well, why was that, and how did that happen, and why do you think you acted that way, and what was that about, and being able to find some perspective on those things, and being able to forgive yourselves. So there's that forgiving yourself piece too. So we talked about sacrament, sick, communion. Those are the kinds of things I think of when I think of spiritual care. I'm probably missing some things. But so again, when you say spiritual care, and some people kind of do that thing to you, I try to, especially if they won't let them through the door, I'll be honest, I just plan a joint visit and they get to come with me. And then they get to meet Nancy, who's just delightful, and I don't say what Nancy's role is. I just tell her, oh, this is Nancy. She's making visits with me today. And they sit and they chat. And then, oh, well, she was really nice. Well, can I come back and visit you again? Sure. Never know the role, but that's okay. They still got through the door. And so it's not just about taking physical care of the person or taking care of their physical symptoms. Sometimes it's the deeper things, it is the life review, it is the spiritual aspect, it is finding forgiveness or giving forgiveness or doing all these things. And so again, a lot of people think hospice, they think we're coming in, the person's dying, they're in bed, we're right at the tail end. And I will admit that many times we do admit patients at that stage of the game. But honestly, the best hospice experience is when they come on at least 6 months ahead of time. 3, 6 months, whatever. There's time for people to get in there. There's time to have discussions. There's time to be supportive and kind of work through those things. Because again, people die better when their other, not just their physical needs, but their other needs have been met as well. And you've had those discussions. So those are fascinating. What else did I have on my list? Is that the end? Oh my God, it's the end of my slideshow. I love that when that happens. Okay. I couldn't remember. I was making a slideshow this morning. Okay. So I have 25 more minutes, but there you go. That is hospice in a nutshell. I have tons of stories, but rather than regale you with those, questions, thoughts, ideas, impressions, things that you'd like to share from your hospice experiences?
So I have a question. When a person is not actively dying, and they come to their caregiver and say they want to end their life.
Ooh. So at 39?
No, at 80.
Okay.
But there are physical reasons they've degenerated sufficiently to be not very
happy with their body.
Happy with their life. Everything around them has fallen away. I was a caregiver and was faced with that situation. And we didn't bring in hospice. I mean, it's a process. They have to meet with their family. They have to meet with their doctor.
Right.
And everybody has to be in agreement.
Right.
Then it proceeds. But we had a caregiving team. But they definitely decline fairly rapidly. It takes a number of weeks. Does hospice ever intervene in those situations that you know of?
And when you say intervene, what does that mean?
Do they are they involved in any
Oh.
way?
Yes. We've certainly had people come on service who have said, I am interested in Act 39, which is the death with dignity
Right.
thing in Vermont. They're different in different states. We do not participate in that process. We don't recommend doctors. We don't do any of that. We don't dispense the meds. That all gets done separately. But what we would do is we would come in and make sure that during that time frame, we are managing people's symptoms and dealing with the other psychological and spiritual issues as they're going along. But hospice is not about keeping people here longer, but it's also not about helping them do themselves in. So we don't do either piece. The goal is to let nature take its course, the disease process take its course, and just help people manage to be comfortable during that process.
So if you have a team taking care of someone
Mhm.
who has made that announcement and made that decision,
Right.
and your team, I had this experience. Some of them couldn't be part of that.
Right.
Is it possible to call a hospice volunteer in to fill in a situation like that?
To actually provide care.
No,
Oh.
just to be
Present.
just to be there.
Yeah.
Okay.
We call that sitting vigil.
Right.
Absolutely. Yeah. I've had people come on to service and they're like, I'm done. I'm going to stop eating. So they stop eating and we keep them comfortable, whatever that looks like, and support the family and help them to have a realistic expectation about what this is going to look like and how long it might take and that sort of thing. And I've had people change their mind and say, you know what, I'm going to have pizza tonight. And they have pizza and then they stop eating again the next day and we're good, And that's okay because the grandkids are coming from California. So, sometimes there's not a straight line. Again, if they were wanting to do it with medications, I'm going to take these huge dose of this, that, and the other thing. We're not a party to that at all. We
No.
will be there to support them and keep them comfortable.
No, and I don't think for the most part that is part of that process. Not that I know of. It's a matter of preparing and making the decisions and then eventually stop eating and then stop drinking.
Right. Yeah. We have a lot of people that just stop eating and stop drinking. They don't necessarily say, this is what I'm going to do, but they kind of do it.
Right.
They kind of take to their bed and they stop eating and drinking and and families are like, well, they're going to die.
It's a little bit better for the family if they have the heads up.
Right. Well,
and can talk about why the parent has made that decision.
well, and sometimes we don't really know. We know it's because it's the anniversary of their husband's death, or it's there might be some calendar thing that's sort of the impetus for them to say, I'm just so done. I'm so done. I would just assume I'm done. Yeah, I have seen that happen many times actually.
Can you talk to how hospice is organized? Like, is it available everywhere in the United States? Do they have individual that are controlled? Like Gary was saying, he had a bad experience, or his sisters had a bad experience.
It was different.
Inside.
It was different.
Very different.
It was just different staff. Right.
Different staff, but it was also the patients themselves.
Right.
My sister was very on guard about the social worker coming in.
Oh,
They're only here to take my money. I heard it constantly. And Frank didn't have any money, so he didn't care.
Frank was happy just to sit on the front porch and have an ice cream with me.
Yep.
God bless him.
Totally different, but it was the
Yeah.
patients themselves.
So hospice is available all over the United States. There are generally when you have, I actually can't speak to other states, but in the state of Vermont, if you are here, if you have an organization that's going to provide hospice services, you have to provide it for the entire state. So that means the upper corner of the Northeast Kingdom, all the way down to Bennington or whatever. So yes, hospice services are available to everyone. I know with the VNA system, They have kind of cobbled and have sections like each individual VNA office, and they're separate.
What's a
Um,
VNA?
Visiting Nurse Association.
Okay.
So they have, a part of the state or states, because living here in these long, skinny states, a lot of times we cover territory that encompasses both New Hampshire and Vermont. And so there's territories that they cover, and Bayonne is the same way. Bayonne covers certain territories. I mean, we talk to everybody. We all know who's got what territory. But yeah, so it's available to everybody. And even we've had people that have they're not on Medicaid yet. They don't have any insurance, but they're actively dying and they want hospice services, and we'll just take them on as indigent care. We can't say no to people. I mean, we can't say no to people. We take care of them. Facilities that had COVID outbreaks where people would not go in. They just seriously would not go in there. They had always said, yes, we will come in and help you care for your people. And everybody that had COVID, they just came on and we took care of them. So, yeah. But it's available everywhere. And for the most part, I cannot think of a single example where any type of insurance didn't pay for it. Medicaid and Medicare always pays for it. And again, we've had people that have they haven't had anything, and they haven't applied to Medicaid yet, and they're on their last legs and they want to go home, and we're like, yeah, we want to make that happen. And the other thing about hospice is that we do have a bereavement team, and I don't know why I spaced that piece, but the bereavement program actually supports families and whoever the caregivers were for 13 months after somebody dies. So, you want to get them through the first year of firsts. The first Mother's Day without, Father's Day without, birthday without. If your family had a big July 4th party every year and now the patriarch isn't here this year for the July 4th party or whatever, so first Christmas without, whatever. We want to get them through all that year first, plus through the anniversary of the person's death. So that's why we always say 13 months. You get beyond that last month. And some of that is phone calls, and some of that is letters that get sent out and said, we wish I could think of it because I've gotten some of these letters, your loved one passed, 6 months ago, you might be experiencing some of these things. These are normal, blah, 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 blah. I have to say my experience, I had two different experiences with hospice. So my mom was on hospice in Maine, and she was on for 5 days before she died. She had a pretty quick decline. And when we knew that was going to happen, actually, when my ex-husband died, he was not technically on hospice because he couldn't be on both, and he was at the Jack Burns Center. So, but thankfully, I worked for Beata, and the social worker would come over, and she would meet with me, and she met with my kids and my in-laws, and they were a wonderful resource, even though we weren't technically on Beata. They loved us anyway and carried us through. And so I was getting letters I was getting the bereavement stuff from Beata, which I found their letters to be wonderful. I would read them and I'd be like, oh, yes, they so get it. They get it. I only ever got one letter from the one in Maine, and that probably was a good thing, because the first letter was something about butterflies, and I don't even freaking remember. I was mad when I read it, to be quite honest with you. I was like, what is this piece of crap? And I threw that in the trash so damn fast. And then it took me a few days to get over myself. And then I called my sister, also in Maine, and said, did you get that letter? And she goes, yes. She goes, I did get that letter. I said, well, what did you think of that letter? And she goes, I really didn't like it. I'm like, oh, I hated it so much, Heidi. And she's like, oh, I did too. I threw it away. So every hospice program does have a bereavement program. Some are better than others. Just going to put it out there. And I didn't realize there was such a variation. I mean, I wanted to take my Beata letters and send them to the hospice in Maine and say, this is what your letter should look like, not butterflies. But I didn't do that. There you go. So bereavement program, I did forget to mention that, and I apologize because that is actually a very important part of the hospice program. And then the other thing is and I don't know about the other program, but for our program at least, if we know of someone who's died in our community, car accident or suicide, whatever, if I know and I know the family, I will ask them if it's okay for our bereavement program to reach out to them. And if they say yes, I give them the information and say, please call them and tell them you could use some support. So even though haven't been on our hospice per se, because they've experienced a death, we try to, bring them into the fold and help to support them as well. So definitely have seen that. Any other questions?
This one might be personal for you, but
Go ahead.
how do you, spending so much time around people who are dying and in stages of dying, how do you take care of yourself to be able to keep doing that?
Excellent question. Sometimes you change jobs.
True.
which is honestly what I did last November. But that had more to do with just the cumulative effect of losing my mom and my ex-husband, to be honest with you. But prior to that, honestly, it's really just making sure I'm not working 24/7, taking time for myself and not spending my evenings documenting when I should be spending time with my family, having family meals together, doing things like gardening for me is a big thing, going for walks. Those kind of things were really important. Some of my patients, they just niggle their way into your heart and they're just the most delightful little things and you just miss them so much. And particularly when you think about at end of life, you're there more frequently. Like at the beginning, I might only see someone once a week. And then as they start to really decline and need more help and more intervention, I might see them twice a week. But people are dying, I'm there every day. You're there and you're making sure families are prepared. Is everything look like it's under control? Do we need to tweak the medications? Do whatever. And during that time frame, it's so intense because it's in a way it's kind of like a birth. You're birthing them out of this world instead of birthing them into the world. And it's a very intense relationship with families in a good way. In a good way, I find. And what I find is when the person dies, usually by then I'm relieved for them because they've been through enough and it's time. Honestly, it's time. I'm relieved for them, but I'm so sad for the families because this has left a big hole in their life, seriously. And when you lose the patient, you lose the family too because it's the next family you move on to. So in a way, there's huge losses as a hospice nurse or any hospice care person because you've developed these relationships, which again are very intense. They're very personal, and you just love these people. Love them and take care of them right to the end. Get them over the cross the line. But I would say the same of caregivers. I often will say to caregivers, what are you doing to take care of yourself? Did you have lunch today? Did you have your breakfast? Okay, well then you sit down. Let me make you a little snack. Let's get something into you first, okay? Because you can't learn anything on an empty stomach, okay? And how are you sleeping at night? Now, you got two people that are staying up at night taking care of somebody. It's like, yeah, you guys got a tag team here. Somebody needs to take the first 6 hours, then go to bed, and know the other person's taking the second 6 hours. So share, and you need to get your rest too. And you got people that are like, no, I'm just going to white knuckle it through it. And you're like, yeah, no, don't do it. so a lot of it is also teaching family self-care and saying, you've been doing this long enough by yourself. I think you need to think about having some help in here. Are there any family members that are willing to help? And sometimes there are, and sometimes there are not. I think at this point you really need to think about some private caregivers, at least maybe just for the 8-hour overnight shift so that you can get some sleep. I don't have enough money or whatever. And it's like, okay, well then let's talk about, you aren't going to be doing this for 6 months. He's on his way out. This may be a few nights. Can you afford that? How can we help you? So do you have a church family we can call on? Do you have a granddaughter? Do you have so it's really helping them also. You can't have them burn out before the end. We all got to make it to the finish line at the same time. And then really just telling people that, it's hard. After someone dies, you love them up, you go, you pronounce them, you do whatever. And you just say, you know what? You're going to have some days where you're going to feel like, yeah, I'll do all right. You know what's going to happen? There's stupid songs that come on the radio, and you're going to be sitting there blubbering. And that's just the way it is. Or you're going to walk into a restaurant and you're sitting there and someone's going to bring the cheesecake out. And that's going to remind you of how much he liked cheesecake, and you're going to be sitting there blubbering. And I was always thankful, and I share this from my personal experience, I was always thankful that my sister and I were never having a bad day at the same time. Okay? So I would call her and say, oh, he's having a terrible day, blah, 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 blah. And she'd be like, oh, yes, yep, you're good, you're good. But then she would call me on a day, I'm having a good day, and she'd be like, bubbling. And so, I encourage people, call your family members, encourage each other, keep in touch, know that you're going to have these moments. They happen. It's just the reality. It might be the smell of bread baking, whatever. You pull the China moon out of the cupboard. That's the other name for cinnamon, by the way. That was our family word for cinnamon, was China moon, because that's how my sister pronounced it when she was little. Anyway, so when I pulled China moon, and especially nutmeg, out of the cupboard, like my mother was always, when she was baking, she'd be like, oh, I love the smell of nutmeg. I just love the smell. And so I can't cook anything with nutmeg now without thinking of my mother. And after I moved out away from home and whatever, if I was cooking and I had the nutmeg out, I'd be like, call my mom up and go, hey mom, smell this. You can hear her on the other end go, oh my God, is that nutmeg? That's nutmeg, Mom. She couldn't smell it, but she knew that was what it was, So nutmeg just makes me think of my mom, So it's little things like that will just bring back those memories. They're just sweet little things, but you got to look at them as positive, sweet little things, even though sometimes you get a little teary-eyed. There you go. I told you got stories. Any other questions? We got 3 minutes. Maybe we don't even have that. Oh, we got 5. I lied. No? Anybody need tissues?
Of course.
Oh, you've got some in your little bag, as a matter of fact. I think you got little packets of tissues in there. Sorry, I should have told you that. Okay.
I wanted to say something about a woman I was taking care of.
Mm-hmm.
Who had cancer, and those of us that worked for her hadn't even had that shared. I mean, we knew on some level, but
right.
We were in there taking care of her.
Mm-hmm.
And one day she said to me, my life has meant nothing. So you really scramble at that point, and your mind is just spinning.
Oh, I'm sure.
But if you have really listened to the patient, the client, mm-hmm. and you dig deep within your own heart, you can come up and say one thing, and they'll go. And for her, I said, there's never been anybody on this planet mm-hmm. who has loved the earth and all the beings on it mm-hmm. as much as you have. Mm-hmm. That did it.
That touched her. Yeah.
She took a deep breath and smiled.
Yeah. Yeah.
She didn't have to be a professor, an opera singer, or a painter. Yeah. She was capable of being all those things and had career paths that didn't mm-hmm. work out because she was trying to do. She was the daughter of a very famous filmmaker. Mm-hmm. So she focused all of her intention on his legacy, mm-hmm. and at the end of her life, she had nothing for herself. Mm-hmm. So,
but how good for you to be able to reach and say, no, but let me point this thing out to you.
That's part of getting really involved with the person and seeing who they are in their heart, mm-hmm. rather than just
right.
That it's so and so,
right.
this old. And these are the family members. There's always some morsel of grandness in each person.
Right. Well, and you took that moment to say, you have value. And she needed to hear that she had value above and beyond whatever this other legacy was, that she had value. And that's a really important thing to say to people.
And she was a trippy person. She was a pilot in World War II.
Oh, I love it. I love it.
I mean, and she swore like a truck driver, and we swore right back at her, and she would lie there giggling. I mean, so some of these people, you might walk in and think that they're really stoic, but if you dig a little bit, my God, the stories that she had were...
There's always a story.
I should
People
write a
always
book
have
about her.
stories. They always have stories. It never amazes me. It never ceases to amaze me. Everyone has a story.
Mm-hmm.
I mean, I think we have like this picture of who we think people are, but once you start hearing their stories, you're like, wow, that's not who I thought they were. But they're actually this delightful person that you never realized was hiding under this facade that they show everybody else. So
Yeah.
that's very nice. Thank you for
Yeah,
sharing that. All right, ladies and gentlemen, that's Hospice 101.
Thank you very much.
thank you.